We're going to talk for just about 10 minutes about the calf and why it's important and why I spend so much of my day talking to patients about the importance of the calf muscle, and it may just be the most important muscle in the lower leg, but I'm sure there'll be some arguments about that. But I spend a lot of time talking about it as a foot and ankle surgeon because I see a lot of problems that are the result of it. And, it's an important muscle for power and for performance. And after all, this talk is about being athletic, and we want to be powerful, we want to compete, we want to push ourselves. But at the same time, we want to make sure we pay attention to the fact that it really can become a problem when it gets too tight. And a lot of that is kind of just genetic. So if we're going to talk for 10 minutes about the calf, we'll spend a few minutes on the anatomy. So the calf is really made up of two muscles here. You have the gastrocnemius, which is the larger muscle that gets a lot more of the attention because it's the one you see kind of anatomically and physically when you look at a person's calf. It's much larger, and it's more in the upper part of the leg. It's really the bulbous, thicker muscle. It has two heads, the medial and lateral head of the gastrocnemius, and then below that is a deeper muscle that really doesn't get as much attention, and it's called the soleus. It's actually the more powerful muscle, but it does not cause as much problems and really doesn't seem to have any pathology that's as significant as the gastrocnemius. And I'll kind of show you why that is. So the soleus is really quite big. This is a cross-sectional picture now, with the front of the leg being here. These gray things are the tibia and the fibula, the bones, and the rest of all the red things are the muscles. And this is the compartment of the leg. So the back of the leg is the calf here, and you've got two portions of the gastrocnemius lateral head and gastrocnemius medial head. And then this big broad muscle, which is much flatter, and that's the soleus. And you can see that it's much wider, it's much flatter, it tends not to get as tight. Now, going back to this slide here, the other thing I'll have you look at is just the fact that the gastrocnemius, where it comes from, is way up above the knee joint, and it crosses both the knee joint, and these two muscles come together and form the Achilles tendon, which then crosses the ankle and the subtalar joint. So in reality, the gastrocnemius crosses two or even three joints, whereas the soleus only crosses the ankle and the subtalar joint, so only two joints. And so the ankle range of motion really varies a lot. What's normal is hard to define, but when we talk about range of motion, we talk about plantar flexion, which is bringing the foot or pointing the toes down, which is the image on the left. And then dorsiflexion, which is bringing the toes up or bringing the ankle up, which is shown on the right there of the screen. And what's normal is usually in the range of 0 to 20 degrees of dorsiflexion. And again, that's going to vary based on which patient you pick or which study or which population you look at. And also it's going to vary with knee motion. If the knee is extended, you're putting the gastrocnemius tighter because remember the gastrocnemius crosses the knee. So the way I test people in the office is both with the knee extended and with the knee flexed, so you can isolate whether the gastrocnemius is tight or if the tightness is in both the gastrocnemius and the soleus, meaning the entire unit. And so my real way of kind of telling the threshold between what's pathologic and what's physiologic tightness of the calf is if a patient cannot achieve neutral, meaning 0 degrees, can't bring the foot up to 90 degrees, while the knee is extended. And that's kind of where it crosses the line for me. A little bit of tightness is okay, and I'll explain to you why that is. So the gastrocnemius is important in the gait cycle. You use it you contract it or shorten it while you're pushing off in the push-off phase of the stance or the propulsive phase. And then you actually need it to extend or lengthen during the contact phase. So if it's tight, there's going to be more pressure in the contact phase. And it can affect numerous different parts of the foot depending on where the tightness is. But if the calf muscle's tight, there's going to be more force going through the foot. And that's really the key to this talk. Tighter calf means more force through the foot and ankle. So calf power is good, like I said. If you tested any one of these athletes here, I guarantee you they'd have a very tight calf muscle because muscles have to operate at a short range of length in order to generate power. And you would not want any one of these patients to loosen their calf muscles significantly. You want them to stay flexible, but you need that power. Jumping athletes, this ballerina is putting a huge amount of force through her ankles with her calf muscle and with the other flexors of the ankle and toes. And then runners, it's a good thing. Runners I find that have very little problems and have been running all their lives, they have tight calf muscles, and a lot of them run up on the front of their foot. And that's natural, and that's what works for them. And you don't want to go and tell this patient, hey, you gotta lengthen your calf a lot. You just want it to remain flexible. And so there's kind of a difference between lengthening and flexibility. But then you want to balance that between tightness, and obviously some tightness is good, but defining what's normal and not is always controversial, and we're changing. But again, what I say is if you can't get up to 90 degrees or neutral dorsiflexion, then that's pathologic. Now, it's easy to kind of have the patient overpower that. If they sit there and they say, look, I can bring my foot way up over this, they're moving through different joints there, and you have to isolate it. You have to have the knee extended, and you have to have the subtalar joint inverted and locked, and that's just something you can get with experience. The other thing I'll point out is the reason why a lot of us get tight calf muscles is because just about everybody, when you sleep, your toes are pointed down, some people more than others. And so that's a big portion of your life you're spending with your calf muscle at a shortened position. And so as we get older, and really in orthopedic definition, I tell patients you're getting older. It pretty much means after you're a teenager or once you hit skeletal maturity. It's sad, but it's true. And so that way I can kind of tell patients even I'm getting older, because they look at me and they're like, who's this young guy telling me I'm getting old? But that ability to get your elasticity and get your motion back is just lost a lot. And even kids get tight calf muscles because as they're growing, their bones are extending beyond the point that the muscles and the tendons can keep up. But they are able to usually catch up, and their things don't become chronic problems, whereas our things tend to become chronic or have a greater tendency. So you want to think about this whole thing as a chain, and you could even go up higher than this, but just think about a chain for a little bit that starts with the hamstrings, moves on to the calf muscle, which is what we're talking about today, which attaches to the Achilles tendon, and then that attaches, and you can see on this MRI picture on the right, the Achilles tendon attaching to the heel bone, which then attaches to the plantar fascia. This is the Achilles tendon here, heel bone here, which is the calcaneus, and then the plantar fascia down here on the bottom, and then the forefoot, which is just a general name for the ball of the foot, or the region just below under the toes. And these are all connected, and if you have tightness that emanates from the hamstrings and the calf, you'll often see damage in another part of the chain if it becomes pathologic tightness and it's combined with overuse and poor training, poor warm-up, things like that. And so that's why it's important. If you look at the patients I see every day, and you look at these injuries, or these problems, these conditions, these are all things that are, I'm seeing probably half my patients have these. And every single one of these things here has been associated in one way or another with having a tight calf muscle or a contracture of the gastrocnemius. And there's many more than this, but these are just some of the most common things. Things like muscle pulls in the calf, Achilles tendon injuries, plantar fasciitis. I mean, if you look around, probably 1 in every 2 of you have had one of these things at one point, and that's the same for my office and my waiting room. And that's why I tell patients, I'm constantly teaching patients how to stretch their calf, and it's good because I've had some of these conditions, and I find if I get up and show them how to stretch every day, that's my stretching for the day, and it helps. So this is not just anecdotal evidence, too. There's lots of research, and just a few of the research things I'd point out is, the way they've been associated. Things like there's an association between plantar fasciitis and having a tight calf. If you look at patients who've suffered from plantar fasciitis, they have tighter calves than control patients. If you look at even trauma, which a lot of people, even in the foot and ankle, doctors didn't really believe it at first, but there's association between a really bad injury called a Lisfranc injury, which is where the foot has fractures and dislocations through the middle of the foot associated with tightness. And you wonder how you could even test that because the patient's got a broken foot. Well, what we would do is someone, after they've had a Lisfranc injury, you test their opposite foot and you look at the motion through that opposite foot. How tight is the calf muscle? And you compare that to just average patients who've never had a Lisfranc injury. And they're tighter, and it makes a little bit of sense because you think if your calf is tighter, if you had a bad injury, like you were in a car accident or had a fall from a height or a bad trip, and your calf muscle is tighter, there's going to be more force going through your foot and a higher likelihood that a trauma goes from being just a minor sprain to a sprain that causes dislocation or instability. And then we can look at associations between treatments and conditions. Stretching improves plantar fasciitis, and then associations between surgery and conditions. Calf lengthening surgery in a large study helps with generalized forefoot pain or metatarsalgia. And there's plenty more than that. So how effective is stretching? Are you going to be able to just go out there and stretch and all of a sudden become one of those ballerinas or one of those hockey goalies that can do stuff like this? I'm never going to do this, and most of us are never going to be able to do this. So it's changed a little bit. When I was young, stretching was about doing it before exercise to prevent injury. There's not a lot of evidence that stretching before exercise prevents any injuries. It's not going to make you more flexible, meaning if you stretch every day, you're not all of a sudden going to become somebody that can just put their hands on the ground easily. But what it will do is within the few hours after you've done it, and many of you may have noticed after you've done a class with a lot of stretching, like a yoga or something like that, you will become more flexible within that session. And that's what we're looking for here is kind of more of it has to be an everyday thing. It's not like you can stretch for a month and make yourself flexible. It has to be a regular thing that you're doing. And patients ask me how to stretch. I always show them a few stretches. I just get a few minutes with every patient, so I show them one or two good stretches that I find are effective, that I think they'll stick to, and I think there's a higher likelihood they'll be compliant with them if they do that, as opposed to showing them 10 things they probably won't do any of them. And then they ask me how much should I do it, and I say do it as much as you can. Make it a part of your routine. There's, all I can tell you is that the more you do it, the more effective it's going to be. And then a lot of patients will want to get into physical therapy a few times a week just to encourage. Yoga, I find, is also very effective. I've had lots of patients who do that and get a lot of relief from their symptoms of things that have been chronic. And then lastly, surgery for tight calf muscles is something that's becoming more and more popular. Foot and ankle surgeons have been doing it for decades, but we're realizing that it helps with more and more things. What I'll tell you is that I don't believe in doing it ever for a high-performance athlete because the loss of power could be significant and affect, if you're an elite athlete and you're somebody who relies on being able to jump up above a rim or, be a high jumper in the Olympics, you don't want to risk losing any of that power. But in many cases for chronic conditions where it doesn't get better despite years of conservative treatment, you can surgically lengthen, and you can do that lengthening either directly through the tendon or through just the gastrocnemius muscle. And the goal is to achieve a balance of strength and flexibility, and that's pretty much it. It's definitely a complex problem, and there's more and more research, and what you'll find is that a lot of doctors in certain camps really believe this is a panacea, and then there's others who think it's kind of, there's some of it, but they even still believe in it a little bit. So there's definitely going to be a balance in there somewhere, and I think I'd put myself somewhere in the middle. Okay? So thank you very much.